So what is biomimetic dentistry? We're conservative. We take a very conservative approach in our treatment, and we want to mimic the tooth structure, function, and aesthetics. We want to preserve the healthy tooth structure. We want to eliminate the decay process by using advanced adhesive procedures, which I'll go into. And we want to use materials that are biocompatible, biomechanically similar to the tooth, in order to prevent fractures and reduce the needs for crowns. Are there downsides? Sure, everything has a downside. It's technique sensitive, okay? The appointment times are longer. You know, I had a resident call me up once and say, how long does it take you to do a class 2 composite? He said, I'm working at a center, and I say I have to do it in 10 minutes. I said, I'm not even getting my mirror out in 10 minutes. It's impossible. I don't know how you can do it in 10 minutes. Is there a higher cost? Absolutely. Okay, when you compare this to traditional approaches. And it requires precise bonding protocols. Those are not bad things, okay? They're downsides to some dentists, but for us, this is what we do. Okay, biomimetics includes such things as deep margin elevation, which we will not discuss today. It involves fiber reinforcement, immediate dentin sealing, which we will talk about, selective caries removal, and of course, non-retentive partial ceramic restorations. This is the world of biomimetics, plus some other things, but this is what you'll be doing if you practice this kind of dentistry. So this is from Pascal. It's the life cycle of a molar. And this goes back to something that Richard Simonson, who's the father of fissure sealants, and I show this in my class, that he showed that if you put a fissure sealant in that lower first molar as it erupts in a 5, 6, or 7-year-old, okay, you can prevent the loss of that tooth. Working in a dental school, we see lots of people come in, and most of the people are missing lower first molars, okay, because that is the first tooth to be lost. I can tell you that was the first tooth I lost. I was brought up in the early 50s, and you know, we didn't know what we know now. So this is courtesy of Dr. Pascal, and you know, clinicians still teach that you should do a traditional GV black prep even if you're placing a composite. Okay, the whole purpose of the GV black prep was designed to retain the amalgam. So what about the management of dental caries? Okay, this I can't say enough about. This goes back to the works of Takao Fusuyama in the 1970s, and it changed the way we looked at dental caries. And I lived through part of this. So in 1970s, Takao Fusuyama discovered that there were various types of carious dentin, namely 3. One was healthy dentin, of course. The outer infected carious dentin and inner affected carious dentin. Okay, the Japanese knew this, and the Japanese designed their restorative techniques based upon this knowledge. Okay, and I'll explain why we got caught in the United States with our pants down, so to speak. He also developed caries dye because it was essential that he could tell one type of carious dentin from another, and he began using caries dye. And to me, this is an essential tool to aid in differentiating the different types of carious dentin. When I was in practice, the caries dye was on my tray because we used it on every single patient. When he also talked about total etch, okay, putting the etch over all the dentin. Okay, what happened was, and I remember these days, it was in the 1980s, that if you put the etch there, you're going to kill the pulp. Okay, the Japanese were using selective caries removal. We were using total caries removal. We were putting the etch on these very, very thin areas. And we ended up lots of root canals. It wasn't until we understood what they were doing is not what we were doing. So I still remember these battles, and we were using glass ionomer bases and everything, when it was just that we were misinterpreting the work that was being done in Tokyo. So we can leave a small amount of affected carious dentin as long as a peripheral seal zone is established. I'll point you to an article by David Alleman in just a minute. This is healthy dentin. The caries stain will not stain healthy dentin, and it doesn't stain bacteria. It stains the breakdown of the collagen. So the more breakdown of collagen, you're going to have a deeper color. So the more breakdown of collagen means you have higher bacterial load, and that's why you have this deep color, okay? We're going to allow the odontoblast within the pulp to produce tertiary dentin, walling off the diseased part. This is what we're using in the dental school. Okay, this is Kerr Optibond Universal 360. This can be used both as an etch and rinse or self-etch. Does contain an antimicrobial to control the MMPs. The original bonding FL, which is like the gold standard for dentin bonding agents, did not contain this, and we used 2% chlorhexidine to control the MMPs. But this does have something, and this also has a big plus. It contains a silinating agent for your indirect ceramics. So this is one product does all. Being at dental school, we use the Unidose, which I kind of like, but it does come in a bottle or the Unidose. They do also make an Optibond Universal without the 360 designation. It's black. It does everything except having the silinating agent. And I'm not sure how much longer that's going to be around, but this is our go-to composite bonding agent now. So one of the foundations of the indirect technique is immediate dentin sealing. This actually dates back to the 1990s and David Pashley, but Pascal took it and ran with it. It's essential for biomimetic indirect restorations. It's also known as pre-hybridization, and what we're doing is we're applying a dentin bonding agent to seal the exposed dentin once you've completed your preparation.